This ask requests that your members of Congress co-sponsor legislation related to the Graduate Medical Education, or GME, the Resident Physician Shortage Reduction Act. The bill was reintroduced by a bipartisan group of lawmakers, including Senators Bob Menendez, a Democrat from New Jersey, John Boozman, a Republican from Arkansas, and Minority Leader Chuck Schumer, a Democrat from New York. On the House side, it was introduced by Representatives Terry Sewell, a Democrat from Alabama, and John Katko, a Republican from New York. The majority of public funding for GME comes from the federal government through Medicare. Additional sources of GME funding include Medicaid, private payers, Veterans Affairs, and other state and federal programs. This investment reflects our understanding as a society that we will all benefit from a skilled physician workforce, so the government should help to subsidize it. Adequate GME funding is essential to training a workforce to meet the needs of our population. Unfortunately, the way we fund GME is no longer adequate. In the coming decades, the United States will face a projected shortage of both primary care and specialist physicians, including cardiothoracic surgeons. Robust forecasting of physician supply and demand from a recent report by the American Association of Medical Colleges identified a projected physician shortage of 40,800 to 104,900 physicians by 2030. Analyses commissioned at the state level overwhelmingly support this conclusion, with 33 states identifying current or future physician shortages, including a nationwide shortfall of at least 1,500 cardiothoracic surgeons by 2025. Specialty workforces such as cardiothoracic surgery are particularly vulnerable to shortages due to the long training time and high debt load. The number of practicing cardiothoracic surgeons is decreasing. There are currently fewer than 2 practicing cardiothoracic surgeons for every 100,000 Americans, with most of these surgeons concentrated in urban areas. That ratio is expected to worsen, as more than half of the current cardiothoracic surgeon workforce is 55 years and older, with a large number expected to retire over the next decade. Meaningful GME reform must address these issues. The physician shortage is driven by many factors, including an aging population, the retirement of senior physicians, an outdated cap on resident positions, a geographic maldistribution of specialists, and the ever-increasing technological proficiencies necessary to be competitive in the field. The federal cap on residency positions was established by Congress in the Balanced Budget Act of 1997. At that time, Congress capped the number of residency positions that Medicare would support at the number of residents who were training in a given teaching hospital as of December 31st of 1996. Even 22 years later, any new trainee position created is not federally funded. Because of the cap, the number of thoracic surgery training programs has remained fairly constant since the late 1990s. In contrast, medical schools increased enrollment by 29% between 2002 and 2018 in an attempt to address the projected physician shortage. As the number of medical school graduates increases and the number of GME training programs remains stagnant, the shortage of GME training opportunities for newly graduated physicians across all medical specialties continues to worsen. As with any policy problem, many different solutions have been proposed. Listed here are just a few of them. One obvious answer is to raise the cap on the number of residency positions for which Medicare will reimburse hospitals. A second is to pursue loan forgiveness or deferment programs, which would particularly benefit those pursuing surgery with its additional years of training and high debt burdens. Since the workforce distribution is also a big problem, it would behoove Congress to investigate the geographical and economic factors that are contributing to the workforce shortage, including a redistribution of residency positions within cardiothoracic surgery programs, pathways of unmatched cardiothoracic surgery applicants, and options for increasing cardiothoracic surgery programs in underserved areas. The Resident Physician Shortage Reduction Act directly tackles one aspect of the shortage, the federal cap on GME positions. The bill increases the resident limit for qualifying hospitals by a cumulative 3,000 positions per year for 5 years. Half of that increase must go towards specialty residency programs with anticipated workforce shortages. The bill also attempts to address concerns about appropriate distribution of GME slots by directing the Comptroller General to conduct a study on strategies for increasing the diversity of the health professional workforce. This will include an analysis of strategies for increasing the number of health professionals from rural, low-income, and underrepresented minority communities. The bill gives first priority to hospitals in states with new medical schools or branch campuses. That's followed by hospitals that are already training more residents than their current cap, hospitals affiliated with Veterans Administration medical centers, hospitals focused on community-based training, and non-rural hospitals operating on an approved rural track program. Unfortunately, you may face opposition from some fiscal conservatives on the Hill who don't support the government funding healthcare. or increasing payments through Medicare. However, the cost of training is not a burden that hospitals can continue to shoulder alone. According to the AAMC, teaching hospitals across the country are already operating 10,000 residency positions without support from Medicare. The University of Arkansas for Medical Sciences Chancellor Dr. Cam Patterson notes that it costs the hospital approximately $200,000 to train and pay a resident. He shared recently, "Without that offset from CMS, it's really difficult to expand the number of residents that we train. Hospitals are simply not able to pick up the slack and train enough residents to care for our growing, aging populations. Situations like this require government support." This bill has been introduced every year since 2009. Last year, the legislation amassed 17 co-sponsors in the Senate and 129 in the House, so we know it appeals to a lot of members. We will let you know whether any of the congressional offices you will be meeting with were co-sponsors of the bill last year. The STS has endorsed the bill repeatedly because of its multi-pronged, direct approach to the problem of projected physician shortage. The Resident Physician Shortage Reduction Act would particularly benefit rural areas. A recent poll by the Harvard T.H. Chan School of Public Health found that 1 out of every 4 people living in rural areas said they couldn't get health care when they needed it recently. The problem will only continue to worsen unless Congress acts now. While not the end-all be-all for addressing workforce issues, this bill is a very positive step. We hope that you will ask your members of Congress to become co-sponsors and help this bill become law.